Wonderful. Thank you. I'm so happy to be here with you all. I'm Melina Marmarelis. I'm a medical oncologist at the University of Pennsylvania. I'm going to be talking about two different topics. The first one is anti-angiogenesis in pleural mesothelioma, and I'll tell you a little bit about what that is. Those are my disclosures. So first, just what is anti-angiogenesis? This is a picture of a tumor, and the tumor sends out a signal that we'll call VEGF, vascular endothelial growth factor, and it sends it out into its environment, and it says, I need more food. Please grow blood vessels to bring me food. So here we have our food truck that's bringing the food to the tumor through now new roads that the tumor has basically signaled to create. And when we talk about anti-angiogenesis, we're talking about actually blocking that feed me signal. Is there a way that we can stop that signal from being sent or stop it from being received? So there are several drugs that work on this. The most common one is bevacizumab, which is an anti-VEGF antibody. And when that's successful, then we have less of the actual blood getting to the tumors, and they grow. Their growth is slowed. So we also call anti-angiogenesis anti-VEGF. So I'll refer to them in both interchangeably. And the first thing I'm going to talk about is combining anti-angiogenesis with chemotherapy. And that's really where this all started. So this is a study that was done in France. It's called the MAPS study. This was a combination of bevacizumab, that's that anti-VEGF drug I was talking about, and chemotherapy. And they were really asking the question, we know that chemotherapy can be effective in mesothelioma. What if we add this drug? So they had a group that got the drug and a group that didn't. And they found that those that got the anti-VEGF drug actually had better survival. And it was one of the first studies to show that adding something to chemotherapy actually was improving survival. So this was actually a really important study, but it was published back in 2016. So this is something that we've been building on. In terms of the next steps, the next question that was asked was, okay, that was the first treatment with chemotherapy. What about some of the chemotherapies that we use as a second treatment or a third treatment? So this is gemcitabine, a very commonly used chemotherapy, not usually as the first treatment, but maybe as a subsequent treatment. And they added an anti-VEGF drug again to that. And they saw again that there was an improvement compared to people that got only the chemotherapy, and again, an improvement in survival. So it's starting to sound like this is actually, a fairly effective drug and can be combined very safely with chemotherapy. So the next question is, what else can be combined with? Can we actually use immunotherapy, which can be a very effective treatment in mesothelioma? And the answer is yes. This is a recent study looking at pembrolizumab, which is an immunotherapy, and a pill actually called lenvatinib. This was a study done in Europe. And I just wanted to highlight, here in the star, I mentioned that these patients did not have any prior immunotherapy. So, here in the U.S., the combination of ipilimumab and nivolumab is a very common combination that's either given as the first or second treatment to probably the majority of people with mesothelioma. They have a little bit more stringent rules in Europe, and so they actually had a population of people that had never seen immunotherapy before, had never seen that combination. So these people got one single immunotherapy, and they added a drug, lenvatinib, that has some anti-VEGF properties. So again, blocking that feed me signal to the tumors. And again, I think Marjorie showed you some nice versions of waterfall plots, but anything now going down and mostly here in the green means that the tumor is shrinking compared to what it was at baseline. And for this particular trial, they look at a cutoff of 30% of the baseline. It shrinks by 30% of the baseline, and about 45% of patients did actually, meet that cutoff. But even still less than 30%, there were some that had a nice response. So just a side note that they also actually did a trial like this in peritoneal mesothelioma, which As you guys have been hearing probably throughout the day, this is a very difficult thing to do. It's very difficult to run a trial for just patients with peritoneal mesothelioma, and this was 20 patients run out of MD Anderson, and they combined an immunotherapy called atezolizumab, so very similar to our other pembrolizumab study, and they added bevacizumab, which is an anti-VEGF. And they again saw that about 40% of patients did have that nice, greater than 30% reduction in the size of their tumors. So again, showing that both the combination of chemotherapy and anti-VEGF as well as immunotherapy and anti-VEGF can actually be quite promising. Now, the two trials I just showed you with immunotherapy, unlike the chemotherapy trials, they didn't have a control arm. So they didn't have an arm that just got immunotherapy. And we know that immunotherapy on its own can also be effective. So there was no comparison there. But still, the numbers that came out of those small trials were definitely encouraging. So in oncology, we like to add things to other things. So the question was asked, if chemotherapy and anti-VEGF is helpful, and immunotherapy and anti-VEGF is helpful, what if we combine all of them together? Can we get more here? And in fact, is there synergy? So there are some preclinical studies in animals and in samples from patients that have shown that combining, in particular the anti-VEGF, can maybe make the delivery of immunotherapy even better. So in addition to reducing the roads, you actually are making the roads that are already there more normal. And so maybe your drug is actually getting to the tumor in a better way. That was the BEAT-MESO study, which was chemotherapy, bevacizumab, and plus or minus immunotherapy. That was presented last year at ASCO, so last June. And that was 400 patients that had never received any sort of surgery or treatment. So this was their first treatment. And those that received the whole combination had a numerical improvement in their recurrence rates, but they did not see a survival advantage compared to those that had just the chemo and the anti-VEGF. So it was a little bit of a mixed result, but certainly something to pay attention to. And just looking back kind of at some of these trials that we've mentioned, I just wanted to bring this figure up. So I think the overall message here is that histology, the subtype of mesothelioma, is so important in determining which treatment is the right treatment. And this is also important in how we interpret clinical trials. So I've put up here a few clinical trials. The BEAT-MESO clinical trial, which we just talked about, is the combination chemo, immunotherapy, and anti-VEGF, but then some of the other trials looking at chemotherapy plus or minus immunotherapy or chemo versus the double immunotherapy, BNevo. And what this shows is that everything, I guess I have my little laser. Let me see if I can get it out. I didn't see it moving last time. Okay. Yeah, okay. Everything on this side means that it favors the arm that has immunotherapy in it, okay? Everything on this side means it favors the arm that had only the chemo. And if it crosses this line in the middle, it means you can't tell. It means there was no definite yes or no. So what you see is, and I've split it up by histology, so you have epithelioid, non-epithelioid for each trial. So what you see is each of the non-epithelioid groups are, very squarely in the group favoring immunotherapy, whereas the epithelioid groups, they are, certainly on the side of immunotherapy, but they're crossing that line. So all of these trials that were positive, they were positive because the non-epithelioid group did so much better in the immunotherapy arm. So where does that leave us? And I know this is a little bit of a segue from what we were talking about before, but I think it leaves us with a lot of different treatment options in both of the subtypes, including a lot of the ones that I've mentioned that include anti-VEGF. So in the epithelioid group in particular, we have an array to pick from, but we don't have good evidence that one is better than another. In the non-epithelioid, we certainly have some evidence that containing immunotherapy, at least initially, is probably a good idea. So with that, I will say thank you. I'm leaving you with a quote from Leonard Bernstein, who is a little known fact, actually he had pleural mesothelioma near the end of his life. He said, to achieve great things, two things are needed, a plan and not quite enough time.
Thank you, Dr. Marmarelis. Any questions for Dr. Marmarelis? Any questions? Right here. Here you go.
Yeah, hi. Lots of the clinical trials is for newcomers, not assessed. What about this group where? Right.
Yeah. So, for instance, the trial looking at gemcitabine actually was in people that had already had at least one prior treatment. So that was one looking at subsequent treatment after the first treatment. I will say the other ones, you heard a lot about, Dr. Zauderer mentioned many of the other trials in that space looking at some of the targeted therapies. I would say that's one of the biggest areas that has grown over the last few years, the TEAD inhibitors, the PRMT5 inhibitors, things that are actually starting to target aspects of mesothelioma that we haven't been able to in the past. And probably the other big group are the cellular therapies, the CAR T cell trials. Those are certainly in subsequent therapy, the subsequent line of therapy spaces. And then actually it's like you're a plant because I'm going to talk about another group of trials. Yeah. Unless there, yeah, thank you. Unless there are other questions.
Thank you again, Dr. Marmarelis.
Okay. All right. So, no worries. Would you like to introduce her? Okay. So I'm going to talk about viral and neoantigen approaches. These are slightly a little bit different than what we've talked about before. So we'll get right into it. Those are my disclosures. So oncolytic viral therapies. So there are two main components to this. One is you need a way to target a tumor and not normal tissue, okay? You can't just inject something into a patient that is going to attack everything. You need it to be somewhat specific to the tumor and if you're going to preferentially kill the tumor. It turns out viruses are actually very good at that, and there are a number of reasons why. But viruses that have been modified, so they're not going to be ones that are causing like the common cold, but then been modified so they're not replicating as fast, actually preferentially will go to a tumor. So when this was figured out, they said, well, we could use this to our advantage. We can actually, create some cancer therapies. So they developed a number of modified viruses. There are two main ways to deliver them. You can give it through an intravenous delivery, through an IV. But actually in mesothelioma, they said, well, why don't we just give it directly to where the disease is? Why don't we put it into pleural fluid that's right there touching along the lining of the pleura? So that we'll talk a little bit about that. And then what is the virus delivering, right? If you can get it to the right place, what is it actually going to give to the tumor? And it's a variety of things, but in most cases, the ones we're going to talk about are actually delivering something that causes a lot of inflammation. So it's a little bit like a local immunotherapy. It's trying to stimulate the immune system, but right where the tumor is. And I see Dr. Sturman in the audience. But there was a very exciting version of this, which was an adenovirus expressing interferon, so another thing that's causing local inflammation and local immunotherapy. This was given through, into the pleural space through a Pleurex catheter, and they saw really nice preliminary activity. So again, here we are with that waterfall plot. Anything going down means that the tumor is shrinking. And this was really exciting. They started a phase 3 global trial. There are a number of, there's some media about it, and the trial opened for patients that had, had more than one prior therapy. And unfortunately, it closed early. It was very hard to actually accrue patients to this. And one of the things that came out of it is that we started to realize that actually we were seeing fewer and fewer pleural effusions. Fewer patients actually had that fluid around their disease, around their pleura, which was required in order to deliver this drug. So that might be part of the better effective treatments for mesothelioma. We're seeing or better and effective treatments for pleural effusions. We're seeing less fluid than we were before, but it was a barrier to actually seeing if this drug was going to work. So unfortunately that trial closed. There is another approach, which is the Wilms tumor protein vaccine. So this doesn't involve a virus, but it does involve essentially a peptide vaccine, which means like a protein that's being injected. And WT1 is not expressed at high levels on normal cells, but it is present at pretty high levels on pleural mesothelioma. So it satisfies that targeting criteria. Can we target the tumor over normal cells? That's why it was a really nice candidate for that. And peptide vaccines basically, if they're injected into the body, they are disguised as cancer to stimulate the immune system. So if you pretend that it's little pieces of cancer floating around, your immune system then all of a sudden picks that up and attacks your actual cancer. So that's the idea behind it. So there was the first study that looked at this, looked at it after surgery in pleural mesothelioma. And what they saw was that numerically, there were improvements in the recurrence rates and in survival. The study was very small, though. So they ran another study out of Memorial Sloan Kettering that looked at it in the setting outside of surgery. So this is now, patients that have had other therapies and then move on to this therapy. And they have treated about 10 patients, have seen mostly stable disease, and safety-wise, it was well tolerated. So I was hoping Marjorie was going to be here to tell us the status of this, but this is something we'll look out for, and this was combined with immunotherapy, so putting a peptide vaccine together with immunotherapy. And then many of you may have seen some of the press releases over another cancer vaccine called UV1. This is targeting something called telomerase, which is part of the cell machinery. And this was a study, about 118 patients in Europe that after chemotherapy, so after first-line therapy, got immunotherapy plus this vaccine injected versus just immunotherapy alone. And actually, the preliminary results looked really great, and the FDA, approved it for fast track as an add-on to Ipi/Nivo back in February of 2024. But then the trial, unfortunately, didn't really see a significant difference, not a statistical difference. So I don't know where this stands. I know they had another first-line trial planned, and I haven't seen the full results of that. So again, I'd like to thank you for your time and all your contributions and for being here today.
Thank you. Any final questions for Dr. Marmarelis?
Oh, there we go.
Hi. Would you mind talking a bit about the mRNA vaccine? So I see that in Europe it's being rolled out a lot, especially for lung cancer as a potential treatment. And I'm just wondering, on the back of, if it's for lung cancer, can there be research into our cancer too, to use that technology?
Yeah. So the mRNA vaccine, so this most recently and most successfully has been shown in melanoma. So there is now actually an approved vaccine in melanoma. In lung cancer, it's still experimental. It's still something in clinical trials. And there have been discussions about applying that to mesothelioma. It depends a little bit about how they structure the vaccine. So they have to pick certain targets. And if those targets are similar in lung cancer and in mesothelioma, the same vaccine could actually be used in both diseases. But I think we're still in a very early phase of those, but I know there definitely are discussions about whether that's possible. Yeah.
Anyone else? Oh, over here. Okay. Feel like Phil Donahue here. He has better hair.
Yes, over the course of the last couple of days, I didn't hear anything about T-cell exhaustion. Is that still a factor?
Yeah, that's a great question. So T-cell exhaustion basically refers to, we've been talking about stimulating the immune system, right? But everything gets tired. So the immune system also can get tired. And so this is something that's been looked into a lot in lung cancer, is if you have exhausted T cells, no matter how much you stimulate them to respond, they're not going to respond. I don't think we have solved that by any stretch of the imagination in lung cancer or in mesothelioma. But there are certainly things that we're looking into. So in lung cancer, we recently published a study looking at adding a JAK inhibitor, which is actually an immunosuppressive agent. We gave it for 6 weeks in patients that were getting immunotherapy. And what we saw is that we saw fewer exhausted T cells when we gave them a little bit of a break. So I think that type of an approach would be really interesting in mesothelioma, and I think it's definitely something we have to pay more attention to, but I don't think we have clear answers on it.
We have one more question, and then we'll move on to our next presenter.
Thank you very much for your presentation. My question has to do with long-lasting effects of some of the peptide vaccines and whether or not there's been a look back at those studies.
I don't know the answer to that. The WT1 would probably be the one that we would have the most accessibility to. So I'm not sure, but in general, the studies on peptide vaccines, I have not seen safety signals that have been concerning, but I think your question is more to not the immediate safety signals, but perhaps the longer term safety signals, and I don't know. I don't have a good answer to that.
Thank you. Final show of gratitude for Dr. Marmarelis.